In today's session, we're going to be talking about team building and specifically how you can take a group of staff and have them actually function as a team. So we'll talk about some practical tips toward that end. And this falls in our Leads in a Caring Environment work under the domain of Engage Others. So the landscape of primary care was challenging before and was changing, but the last 2 years have really accelerated things. And so with increasingly complex patients and physicians and other care providers leaving or retiring early, a team approach to patient care is really emerging as a critical strategy for family practices to be able to manage this increasing demand and workload. But turning a group of staff into a team doesn't happen automatically. It requires a process of engagement. So during this session, we'll talk about some practical tips and strategies. Now, there are many strategies for engaging staff members to work as a team, but we're just going to focus in on 3 today, specifically building agency, roles and responsibilities, and giving introductions to patients with intention. So first is agency. Now, we often talk about empowering people, but the word empower has actually become a bit controversial lately. So this quote captures the current sentiment in the field about the word. It says, one of the most dangerous words we use is empower, usually used to describe those typically underseen and underserved. They need us to empower them. So empower them keeps one above and one below. It's how the status quo perpetuates. So instead, we're going to use the word agency, which has been defined as the power and ability to make choices and act on them freely. So this is an interesting model. It's called the hierarchy of capabilities. So as an example, down at the bottom part, the bottom half of this pyramid hierarchy, if Mary is hired as a receptionist in your clinic, you can expect those lower 3 aspects of the hierarchy. So you would expect that she would be obedient in a sense that she's obeying basic rules like coming to work on time. And then she's diligently carrying out her assigned duties, like responding to phone calls. And that she will bring a certain degree of expertise to the role, like being able to manage booking software. So these are, expected qualities. But the qualities that make for great team members are initiative, creativity, and daring. So for example, if Mary was at this level, when she became aware of an inefficiency in the reception process, she would probably come to you with some ideas for how it could be improved. But if she was operating in those lower 3 categories, she might either just carry on doing things how they've always been done, or she might come to you with a problem saying, this needs to be fixed. So it's definitely easier as a leader to work with people who are in those upper 3 categories. But how do you get them there? So there's a few tips for building agency on your team. And the first is to look for opportunities for improvement and make that part of your culture. So encourage everybody to always be looking for ways to make things better. And so, if people do see opportunities and they bring them forward and they're met with, no, we don't have time to do that. No, just carry on as things are. They're not going to be bringing anything forward in the future. So even though things are busy, it's about having a positive attitude toward acknowledging that there are areas that can be improved and acknowledging that there's a desire to make things better. Even if it's slow and happens over time, there is a desire to create a high-functioning, efficient clinic. Then the next tip is to brainstorm ideas together. So even though the idea may have come from Mary, the receptionist, if that idea is then brought to a larger group, even people who aren't working in the reception area, that's where you get really great ideas. To get a good idea, you need to gather lots of ideas and to brainstorm things that might be crazy, things that maybe are realistic. But eventually you get down to the really good ideas to test out. So brainstorming ideas together can help you get the best ideas. And then there's the idea of shared leadership. So traditionally in clinics, often leadership just naturally falls to the physician. But in a real team setting, there's shared distributed leadership. So for instance, if there are meetings, it's not always the physician who's leading them. Sometimes it rotates, or there's a group of people who are interested in leading those meetings. Same thing with small QI projects, larger QI projects. It doesn't have to be the physician who leads these. Sometimes it's surprising the leadership skills that emerge when people are given the opportunity. Right, next one is reframing failures as learning opportunities. And again, sometimes when things go wrong, if we work hard to, cover them up, or if we assign blame, then people are going to hide mistakes in the future. But if we view failures as opportunities to learn, so we acknowledge that this happened, there's no blame or shame attached to it. We just want to learn how to avoid the same mistakes being made again in the future. So when a team sees that failure is not punished, it's viewed by the whole group as an opportunity to learn. That's when psychological safety is built. That's where trust is built. And it's where the team can really start improving, because you can't improve if mistakes are hidden. And then the final tip is to really celebrate and recognize. So celebrate not only when your goals are reached, but little milestones along the way, and then recognize the efforts of individuals. So however you want to do that in your clinic, it doesn't have to be big, it definitely doesn't have to cost money, but even just verbally recognizing the efforts of people goes a long way to give them that energy to keep going in the future. So a couple other little tips. I mentioned psychological safety, and it's something that we talked about in depth in a previous session. And that really is just when people feel safe to bring forward an idea, or in particular a criticism, that they feel safe, that they won't be punished, that they won't be ridiculed, that their ideas will be met calmly and with a healthy view to improving, with our goal to always make patient care better. And when teams have psychological safety, they can have healthy conflict as well. So they feel comfortable and safe to bring forward things that maybe don't agree with the rest of the group. And again, this is where really good change happens, when you have people who feel safe and comfortable to go against the grain. Another tip is to keep it manageable. So again, sometimes when we start working on making improvements, people get excited and they want to do a whole bunch of things at once, and that can become overwhelming very quickly. And then really nothing gets accomplished. So you have to kind of rein people in a little bit and just make sure that you're tackling a reasonable amount of work on the QI front. Now, there are quite a few clinics who do this really well, and some of them will have a whiteboard up in their meeting room, and people just write up on the board when they notice something that might be worth improving. They write it on the board, and then at team meetings they'll go through the board and discuss different opportunities. And they might notice that something might be sixth on the list, but it actually is important, and so they might prioritize working on that first. Or sometimes they'll push it off till a bit later when they've got more time and space to work on it. And then with the shared leadership, often whoever brings it forward, if they have a passion for it, if they're quite interested in it, often they can take on the role of leading that work. And when people have that opportunity, it really helps with retention, because they feel like their efforts are recognized and they have an opportunity to grow at work, which is important. And then the third thing is, you can't really do any of this stuff if you don't have meetings. So as much as no one likes meetings, you really can't accomplish any of this without them. Definitely you can operate as a staff without meetings, but it's really difficult to operate as a team without meetings. So they don't have to be onerous or long or boring. You can have really efficient meetings. You just have to put a little bit of effort into it. And again, this is a great place to share the leadership. So maybe someone is interested in doing a little research about, how we can structure our meetings, how we can run our meetings so that they're as efficient as possible and everyone is heard, which brings us to the next point here. And I know I talked about this in a previous meeting about teamwork, and I think it merits mentioning again. Beware the hippo effect. So often when there's a hierarchy, as there, even though it's unspoken in a clinic, there's usually a hierarchy, and hippo stands for the highest paid person's opinion. And so often that opinion is the one that people just accept without really thinking about or challenging. And it's often subconscious. So, when a question is asked, people will just automatically look to, usually it's the physician at the table, and whatever they answer, people will just go with it. They won't challenge it or they won't share their own opinion. They'll go with it. But a lot of really important ideas can be missed that way. So a good rule of thumb is that leaders speak last so that you hear the ideas of everyone in the room first. All right, so that's it for agency. Next up, we have roles and responsibilities. So very often when people are underperforming, it's because they're not clear. They're not really clear on what they're supposed to be doing and what others are supposed to be doing. And sometimes, especially in large clinics, one role has no idea what the other roles in the clinic do. It's very isolated and siloed. So to truly function as a team, each member needs to be able to see the big picture of whatever process we're talking about, and to understand what their roles and responsibilities are in that process and what the roles and responsibilities are of others who are involved. So this is just a chunk of a table that is a simple tool that can be used to have discussions around roles and responsibilities. So that role clarity can be provided during a meeting. And again, it takes a bit of time, but if you have a really important process, and it could be related to a quality improvement process, or it could be a clinical process, up in that top left blue box, that's where you would write whatever the process is. And then underneath it, you list out all of the associated tasks in that process. And then you start to fill it out across. So if we use the example of giving flu shots, in the first column next to it, you see who could do it, meaning who is it in scope for. So in this case, the doctor, the RN, the LPN, and the PCN pharmacist have all had training, and it is within their scope to give shots. But when we think about who has interest, experience, and availability, we see that Susan, the RN, has done it quite a bit in the past, has an interest in it. And Mark, the pharmacist, has also had training and experience. Now, while our LPN has had training in it, it was several years ago, and she doesn't feel completely confident in it at this point. Now, in the discussion, it's decided that Susan, the RN, will be the one who is responsible for overseeing and delivering most of the injections, mainly because she works full-time, and Mark, the pharmacist, is in 3 days a week. So he will definitely support and help when he's there, but Susan will be the lead. And then Chris, the LPN, will be cross-trained because although she's maybe a little rusty, it is in her scope. So she's going to learn. Susan will oversee, making sure she's comfortable and confident. And then over time, Chris knows that her role will expand. And that is also really good for her morale and feeling like she's, again, growing and learning in her job, which is more likely to keep her around for longer. So this is the full sheet, and we'll make sure that a blank and customizable version of this form is included in this session summary that will come out after. So next up is introductions with intention. So having Susan give flu shots now might be a big change for patients who are used to having the physician give their flu shots. So how the idea of someone else managing clinical care is introduced to patients can make a big difference in the patient's acceptance of this transition. So we like to call it the warm handoff, and there are a few characteristics of that. And the first is that when the clinician doing the handoff is talking to the patient, they tell them not just about the role of the person, but also the name of the other clinician. And they express that they personally know and trust that person, and that that person has experience and knowledge. And then finally, and especially in the case of a physician, they reassure the patient that they're still the primary care provider and that all information will flow back to them. So let's look at an example of what we'd call a cool handoff. So the doctor says, I'm going to refer you to the PCN CDM nurse to help you manage your diabetes. And this sounds perfectly reasonable to us, especially. But to the patient, she probably heard acronyms that she didn't know and a stranger that she doesn't know, and she's wondering if maybe she's getting a raw deal here. So she probably won't say anything in this interaction, but there's a really good chance that she won't go for an appointment with the PCN CDM nurse, and she'll probably just keep booking to see her own doctor. So this is the same situation with an example of a warm handoff. And in this case, our physician says, I'm going to refer you to Susan, a registered nurse I work with, who is an expert in helping people manage their diabetes. She actually knows more than I do about things like nutrition. My patients really like her. She'll keep me up to date on how things are going. And of course, I'll still be here when you need me. So in this case, our patient is probably a little more willing to give this a try. And it takes a little bit of extra time, but the time spent making an introduction with the intention of making the patient feel comfortable and safe seeing someone new will likely pay off when she actually engages in care with the nurse. So that's it. That's all three of the strategies. And now we'll move into breakout rooms to discuss them.